Mental health crisis care in the U.S. is in distress. The number of people who are dying of suicide, the struggle of individuals in emergency departments, people going to jail because better crisis care is not available. And a group of us put together the Crisis Now document to highlight that effective strategies are not only possible, but being performed today here in Arizona. 3 key services: an air traffic control call center that navigates and focuses on the person till they get what they need. Community-based mobile crisis that doesn't require someone to go to the hospital, but meets them where they are, on the street, at their apartment. And if they need it, a crisis facility they can go to that will see them right now. Law enforcement can bring them there and go back and do their job. Those are 3 simple things, but they make all the difference in mental health crisis care being effective, inexpensive, and safe for a community.
We really are a team with law enforcement, with emergency response, with the providers of behavioral health. It takes more than just a call center to answer the phone and tell somebody else to go do something. We do our absolute best to take care of people who need us the most.
We're dispatching approximately 50 to 75 calls daily to the 8 counties that we provide services for here in southern Arizona. The Crisis Mobile Team is so fortunate to have the modern technology that we have now. We have a system called a DOT that has a GPS that is able to pick up on the phones and is able to send the activations to our Crisis Mobile teams that are on hand that are going to be out in the community. For example, if somebody's in crisis and they're in Yuma County, I'm able to look at the DOT and find out which one of the 5 Yuma teams I have available is geographically closer to the member in crisis.
Once we activate a mobile team out to the member, more often than not, they will call us back to schedule an intake appointment. Looking at the numbers through September 30th, we've actually scheduled a total of a little over 4,500 appointments. Out of those, 3,500 were intake appointments. It's a great collaboration that we have with our providers here in southern Arizona to make sure that our members are set up with those services.
The purpose of the call center is not simply to take calls and route them, or take calls and manage the issue or the challenge at hand, but is to serve as a comprehensive management of the situation and delivery and connecting point for individuals through warm handoffs and transfers between whatever network of service providers there are in the community. And the underlying element that makes it so intelligent is robust data systems, infrastructure, and being able to move data and information fluidly between various providers and various community stakeholders to effectively manage individuals' input, throughput, and output within the crisis system continuum. There's no doubt and no question in my mind that the effectiveness and the efficiency of this process, one, provides the best care possible to an individual in the most dignified and honorable way. It's going to be the most cost-effective process for the taxpayer base and the healthcare industry, and that as professionals that we can go home at night ethically viewing that we've done the best we can in the right way.
And mobile crisis is an integral part of the crisis system within the state of Arizona. It comprises 2 team members. One is a master's level clinician, one is a bachelor's level person or a behavioral health technician. When law enforcement shows up to an individual's home who's in crisis, they have their lights on, it's very obvious that they're there, and it can be embarrassing and it can be traumatic for the person who's in crisis. But when mobile crisis shows up, they come 2 people that get out of an unmarked van. It just looks like 2 old friends that are coming to have a visit. And they're able to identify people that can help them, that can provide that support to them to help keep them safe. It doesn't matter where we do interventions, it's less costly and it's more effective because it's right to the person who's in need.
The emergency room is pretty much the worst place for a person who has a psychiatric need. I used to work in a level 1 trauma center, and I would do psych consults in the ER. And I would be sitting there trying to do an interview with someone who was depressed and suicidal as they were wheeling gunshot victims behind me, screaming and bloody. The best thing is to get them out of that environment where they can be surrounded by people who are trained in behavioral health, trained in de-escalation, can give them the space that they need and the support that they need and a little more time rather than this push to get them out because they don't really belong there. We have to be easier to access than jail because cops are busy. They didn't get into being a policeman, woman, to be a social worker. They just need a place to bring people and then they can go on about their business and free up their time to be doing what it is that they're best at doing. half of our volume comes via law enforcement. We've had up to 7 cop cars back there. We take them one after another, and when we do that, we bring extra staff up into our Sallyport area because we want to get them in and out as quick as possible.
But once we hit the facility, you're talking 3 minutes where the officer is dropping off the patient and getting those resources to the individual. If you look at what's happening across the country, you know, when in relations to officer-involved shootings, a lot of that has to do with how the officers are interacting with individuals that are in crisis. We have to be better educated. We have to have those skills to understand and recognize mental illness and how to deal with that. So the most important thing that mental health providers and law enforcement can do is continue that partnership to work out issues, to make the whole system more efficient. And it has made us more educated in the field of mental illness. I believe we've made mental health providers more educated in the policing side of it. We're serving our community, and you have to do it together.
So when we free up an officer's time, they're back on the street, they're back in their car, they're answering calls, they're not sitting at an emergency room. That's our purpose. That's why we work with law enforcement. I've trained all of my staff, and then they've trained their staff, and it's been our culture for the last 20 years. You never, ever, never, ever refuse services for a law enforcement or any first responder. That's what we're there for. We are the safety net for the safety net, and we will never tell an officer to go somewhere else. It's hard for me to even think about not accepting a person that a law enforcement officer brings to us. We are the responsible agency in the community.
The state of Arizona crisis system is an exemplary model of how crisis systems could be delivered. There has been a look both at the clinical models. What does it really take clinically to intervene, to do engagement skills, to serve people? But there really is also all these business aspects, and it's the two coming together, having the technology, having the analytics, thinking through the different business structures that an organization can have. Bringing both that and the clinical together is what really makes a difference in delivering care and having the cost savings and the outcomes that we so desperately need.
Crisis Now is a different approach, and it's been fueled, it's been inspired by our successes in Arizona. If we can do that here, it can be done anywhere.